Hello, everyone, and welcome. Thank you for joining us today for this question and answer session. I'm Dr. Alan Miller, Executive Director of Beck Institute for Cognitive Behavior Therapy in Philadelphia, Pennsylvania, in the United States. I will be asking questions of Dr. Judith Beck, who, along with her father, Dr. Aaron Tim Beck, founded Beck Institute in 1994. We received over 400 questions from all over the world, and we've selected the ones that were most frequently asked. We will also take live questions from you, which you can submit through the Q&A feature of this webinar. Judy will also respond to many more questions in our newsletter, our blog, and social media. So be sure to subscribe and follow us in the coming weeks and months. Judy, thank you for taking the time today to share your experiences with us.
Oh, thank you, Alan.
If it's okay with you, let's start at the beginning.
Sure.
Not everyone knows how your father developed his ideas about CBT. Can you talk about how he transitioned from being a trained practicing psychoanalyst to becoming the father of cognitive model of psychotherapy?
Well, it's really a very interesting story. My dad was a psychoanalyst. He went through two bouts of analysis himself with two different analysts, and he had his patients lie on the couch and do free associations while he would make certain inferences about what they were telling him. But really, first and foremost, my dad was a scientist. And he really bought into the whole psychoanalytic model. But he knew that if psychoanalysis was to be accepted in the scientific world, that its concepts would have to be validated through research. So he started a series of research studies with depressed patients and normal controls to test some of the psychoanalytic ideas. One of them was that depression is a result of anger turned inward toward the self. Another one was that people who are depressed have a need to suffer. Well, he was very surprised when not only did the research not validate the psychoanalytic concepts, but it actually, the results were actually opposite to what he had expected. So I think a lot of people would have thought that maybe their research was faulty in some way, or they hadn't analyzed the data in exactly the right way. But my father, being a scientist, believed the data. And he started then searching the literature and research to see if there could be different explanations for depression other than the ones he had learned about through psychoanalysis. About this time, he made an interesting discovery among some of his clients who were free associating. Every once in a while, a client would say something that surprised him. One client, for example, said, "You know, Dr. Beck, the whole time I was talking to you, I was feeling anxious." And he said, "Oh, well, you didn't say that." And she said, "No, I know, but the whole time I thought that you were disapproving of me." And so that gave him this insight that people often have two streams of thoughts that might be going on simultaneously. One, it might be the kinds of things that they're trying to think about and maybe express out loud. And the other is an internal communication system that he later called automatic thoughts, thoughts that just seem to pop up into people's minds. Well, he found that when he was able to help people identify their automatic thoughts and evaluate them to see how accurate they were, how helpful they were, and so forth, that they very quickly started to feel better. So he then started to have people sit up in a chair at either the desk or around a table with him. And he learned quite a lot from behavior therapy in terms of structuring sessions, monitoring progress, assigning self-help assignments for people to do between sessions. And so that was really the beginning of what he called cognitive therapy that is now known as cognitive behavior therapy.
Yeah, so just incredibly high level theoretical work, clinical work, and research. So, Judy, what did you know about your father's work as you were growing up?
So, not much, I have to say. My father was a very traditional father and family man. So I grew up in the mid to late 1950s and 1960s, and he just worked all of the time. He worked all day, he worked all weekend. And one thing I did know that was different about him was that he wrote books. And it seemed to me that none of my friends' fathers wrote books. So that was one difference. Also, when I was we're not exactly sure, I was either a preteen or a young teenager. He told me his theory, the cognitive model, that the way that you think about a situation is more closely connected to your reaction, how you feel emotionally and behaviorally, and how you feel emotionally and physiologically, and what you might do behaviorally. These thoughts that you're having are more closely connected to this reaction than the situation itself. And he gave me an example, and I said out loud, "Yeah, that makes sense." But in my head, what I thought was, "But that's so obvious." So I think from from a young age, what little I knew of his work made sense to me. I'll just tell you one other funny anecdote. I was in a very large psychology, fundamental psychology course at the University of Pennsylvania when I was a freshman there. And this was taught by Martin Seligman. And at one session, he passed out to about 200 of us in the audience the Beck Depression Inventory. And I did know something about that. So that really impressed me.
So early seeds of what was to sprout in you in the future. But to go from the beginning more toward the end of his life, recovery-oriented cognitive therapy for individuals diagnosed with serious mental conditions was the focus of your father's work during the last 15 years of his life. What's the significance of that?
And in fact, he was still doing some work fine-tuning this 2 days before he died at the age of 100, which was in 2021. And he said he was more passionate about this adaptation of CBT than he was about anything else he had done in his career. And I do hope people will be motivated to try to find out more about recovery-oriented cognitive therapy, which I'm now going to call CTR. So CTR is based on the cognitive model, of course. It's important to know that research shows that when you do CBT in the traditional way, you decrease the strength of people's negative beliefs and their psychopathology, but you don't necessarily increase the strength of their positive beliefs. And in CTR, the emphasis is very much on the positive. We help clients engage in positive activities, sometimes right in the session, especially if they have serious mental health issues right in the session, but and also between sessions for people that we see more on an outpatient basis. But it's not enough just to have positive experiences. We need to help people draw positive conclusions about these experiences. We ask them, "Gee, the fact you were able to do this, what does that say about you?" Or "You had predicted that you wouldn't have enough energy to do this or that. What did you find out?" Or "I think you had told me that you thought people might reject you if you engaged in some interaction with them. Doesn't sound like that happened. Is that right? So now do you have a different understanding about other people and about yourself?" And when you help them draw these positive conclusions, it increases the strength of their positive beliefs. So the emphasis is on recovery, resilience, and empowerment. We teach patients how to identify their aspirations, their really big desires and dreams for how they want their lives to be, how they want to be. And we also help them identify their values. And a lot of the therapy, a lot of the treatment is really oriented toward helping them live in alignment with these aspirations and values. So at every session, we help clients identify the steps that they want to take this week. We do that much more than finding out what problems they had in the past week. Much more, we'll say, well, what is it that you would like to do in alignment with your values and your aspirations in this coming week? And then we have to find out what challenges would get in the way. And oftentimes the challenges have to do with negative thinking or lack of skills or some problem that needs to be solved. So we use more traditional CBT techniques to help them overcome these challenges. So what happens is when we work in this way, we help people increase their sense of connection, control, their sense of competence, and their sense of purpose and meaning, and their sense of hope. So that's just an overall picture, which needs to be fine-tuned according to whether you are treating people who have been in the hospital for 20 or 30 or even 40 years, or whether you have more of a run-of-the-mill kind of client who you're seeing in your outpatient practice.
But a full enhancement and addition to the original work, which makes it increasingly more helpful to more people. But Judy, now that we've talked about your father and his contributions, many people know about you because of you wrote the book, Cognitive Behavior Therapy, Basics and Beyond. That's been translated into 20 languages. How did you conceive of this book? And what parts do you think are most important?
So I began, when I began supervising people, and it's always, by the way, based on listening to entire therapy sessions. This was probably in the late 80s, early 90s, when a lot of people who were experienced therapists had not had very much exposure to CBT, but really wanted to know more about it, wanted to learn how to do CBT. And it always surprised me about the kinds of difficulties they had. And whenever I came across a difficulty, I would take notes on that. And eventually it became the first edition of Cognitive Therapy Basics and Beyond, which was in 1995. But they had problems such as differentiating between emotions and cognitions. One of the really important parts of the book is called the cognitive conceptualization diagram. It was really clear to me when I listened to a therapy session and talked to a therapist about the client, how it was that the client came to have the difficulties that she was having. And of course, the current difficulties were very directly related to her perception of ongoing situations, present-oriented situations, her perception of them, and then her reaction to them. And it was pretty easy for the people I supervised to understand the cognitive model in that way. What was so much more difficult for them was to figure out what the client's core beliefs were, her most basic understandings about herself, her world and other people, and her future. And they didn't understand the connection between the meaning that she had put to earlier experiences and her core beliefs. They had a little bit of trouble also understanding the connection between the patterns of maladaptive behaviors that she was using and how that was connected to her core beliefs. And they particularly had trouble identifying their intermediate assumptions or intermediate beliefs. And these were the assumptions that link the maladaptive coping strategies to the negative core beliefs. It goes something like this: if I use this maladaptive coping strategy, then I'll be okay, at least for the moment. But if I don't, my core belief will come true or be evident. So the conceptualization for the patient was very clear to me, but it wasn't clear to the people I was supervising, which is why I developed this diagram. Okay, so that's how I came to write the book, and then I did a second edition and a third edition. And for all three editions have two of the three things that I think are most important. One, as I just mentioned, is the cognitive conceptualization. The second one is how to establish and maintain a very strong therapeutic relationship, because if you don't have a strong one, the patient may not come back to the next session. And then the really important addition to the third edition is adding a recovery orientation. So I took the principles of CTR that my father and Paul and colleagues wrote about in a book you might want to take a look at called Recovery-Oriented Cognitive Therapy for Serious Mental Health Conditions. I took the principles and then applied them to the people whom we see on an outpatient basis. So very quickly, those are the first three things that I think are most important.
Wow. Your thinking and your writing has had just a tremendous impact on the work of untold numbers of therapists, have just had a tremendous impact on the field.
Thank you.
An aspect of it, though, although you and your father have written and talked about the importance of the therapeutic relationship and individual conceptualizations, as you were just referring to them, there are those who say that CBT is rigid, formulaic, cold, impersonal, even superficial. What do you say about that?
No, I've heard all of those things and it makes me a little tired. Okay, so those could be characteristics of someone who is doing CBT very poorly. It could also be characteristic of people, of therapists who are required to follow a treatment manual that doesn't really take into consideration the individual characteristics of each client. But the way that we teach CBT at the Beck Institute is quite different. As you mentioned before, we do an individualized conceptualization of each client. We adapt the treatment in terms of the client's characteristics, age, education level, developmental level, take into consideration their family history, their educational and medical history, and I could probably rattle off 10 more things. And we use the conceptualization to plan treatment, moment by moment within every session. And we also use the conceptualization to plan treatment across sessions or across treatment. And as we were also talking about a moment ago, is if a therapist is coming across in a cold, impersonal way, I would say that that is a huge flaw and not something that we espouse in CBT. I guess I'll leave it at that.
Okay. Let's change direction just a little bit, because we have received a lot of clinically oriented questions from this audience. Here are a few that were asked by a number of different people. First, how do you use CBT to motivate a purposeless, lost person?
When someone shows up in my office and is purposeless and lost, they're usually operating in what the CTR would label as the maladaptive mode. Usually they have very strong negative beliefs that are activated pretty much all the time, and especially in your office. And their positive beliefs might be completely unactivated, deactivated, I guess I should say. And as a result, they make very negative predictions about their life in general and about how therapy won't be able to help them. And they frequently will engage in maladaptive behavior, as I described before. So the first thing that we have to do is to get them out of the maladaptive mode into the adaptive mode, where there are more positive beliefs and positive predictions and more adaptive behavior are activated. One way of doing that is by talking to them about something that has not much to do with therapy, but it does have a lot to do with what they're interested in. What, if you can find out what they're passionate about, what they really want to talk about. If you can do that for a few minutes, then you may be able to shift gears a little bit and ask them to describe to you what was the best period in their life. And you want to have them go into a lot of detail. What was really good about it? What kind of positive events happened? What conclusions did they draw as a result of those positive events? What were some of their positive beliefs? What were some of their positive relationships like? How did other people with whom they had positive relationships view them? How did they view themselves, their worlds and other people? So we want to really get a good idea of the patient's best period, of his strengths, his positive beliefs, and also what did he want for his life back then? What were his aspirations during this best period of his life? What was really important to him then? What were his values? And then we can talk about whether the patient still has the same aspirations and values, and whether these are things that they might be willing to work on in treatment. Now, sometimes we have to reassure them that, of course, we're not going to be able to do everything at once, and we can talk about just taking some small steps every week, ones that they think that they might be able to accomplish, even if they have some negative ideas like, well, this won't help at all. Then if we have a strong enough alliance right in this first or second session with them, we might be able to get them to do some experiments in the coming week to change their behavior in some way and to see what happens. So there probably are a lot of other things that I could talk about, but that's how I would get started.
So we know that CBT has very broad application, but are there any diagnoses or challenges that CBT just isn't equipped to handle?
So the answer is we don't really know. Just about all of the research so far, when it has been done credibly, shows that CBT can help. Now, it doesn't mean that CBT can always get people into remission or cure a person necessarily. If someone has autism, for example, we're not going to cure that, but we could help them function at a higher level and certainly improve their mood, for example. If somebody has cancer and it's a terminal case of cancer, we're not going to cure them of that, but we can help them think about how they want to use the time that they have left and see what kinds of challenges might get in the way of their doing what's really important to them. For all of the diagnoses, the psychiatric disorders for which there's been research, pretty much has shown that CBT is effective. But I have to caution and say that the treatment for, say, panic disorder shares some components that are similar to a patient who has depression, but there are also some really important differences. And this is kind of the challenging and interesting part about being a therapist, is that it's very important to find out what are the mechanisms of action for each of the different disorders that you're treating, and how do you have to adapt therapy, not only so it's right for the individual, but also so that it really applies to the conditions that the patient has.
So this is a little bit more about perhaps the personal skills of the therapist. How can you tell clients that they're engaging in cognitive distortions without offending them?
So I would actually never tell a patient that he is engaging in a cognitive distortion. And I actually don't give patients a list of cognitive distortions either. This is what I do. So a patient is telling me about a problem. Maybe it's a problem from the past week. Nowadays, it's more likely a problem that is likely to get in the way of his taking a step in the coming week that he wants to take. So I hear what the problem is, and gosh, I got so involved in that, I forgot what the question was.
It
Oh,
was
about the distortions. Okay.
about,
So I hear what the patient's problem is, and then I find out whether there are some automatic thoughts that might be getting in the patient's way. If it looks like there are, then I might say to the patient, would it be okay if we take a look at this thought that you're having? And if the patient agrees, then I would probably use Socratic questioning. There are a lot of other ways of addressing automatic thoughts, but let's just say I did Socratic questioning. If I find that the patient's thoughts contain all or nothing thinking, for example, and I really see this as a pattern, it didn't show up just once, but maybe I've heard it 3 or 4 times. I've recognized it 3 or 4 times. Then the 3rd or 4th time, I might say to the patient, it's after we've evaluated the thought and he's now thinking about it in a different way, I might say, I wonder if you think that maybe you were having some all or nothing thinking in there, that either you were a complete success or you were a failure. And if he says yes, then I might say, I have a feeling that there may be some other times when you see things kind of in black and white terms. In fact, we call this all or nothing thinking. Do you think I could be right about that? So that's how I would bring it up. It would be in the context of a specific automatic thought that contained a distortion that I had heard at least once or twice before. And then I would bring it up as a possibility to the patient and see whether the patient would recognize that. And if so, then I might suggest that the patient just take a look at in the coming week or weeks for other times when he might be making this kind of distortion.
okay. So now there are some questions that get more involved in different kinds of societal and systemic kinds of issues. So what can CBT practitioners do to adapt treatment when a client has experienced systemic racism, oppression, or discrimination?
Okay, so let's say you have a client from a minority group and he's in a minority group because it might be his race, his culture, his religion, might be his sexual orientation or gender identity, or maybe some other characteristic. But he's in the minority group, which is different from the dominant majority group. And he also might have been adversely affected by social determinants of health and well-being. And if that's true, it's going to be very important during your initial evaluation to find out whether having this minority status has led to negative and sometimes traumatic experiences to which he has put negative meanings. You need to include these meanings in your overall conceptualization of the client, because the meaning might have negatively influenced what the client believes about himself, his world, and other people, and or the future. Now, let me just give you an example. Let's say you have a depressed client. He's from a racial minority and he wants to join a group in his community, which mostly has members of the racial majority. When he was turned down, he assumed it was because he wasn't smart enough or good enough, and I'm sure that was related to his depression. And so it would be very important then to examine the evidence and to see whether there was some other explanation for why he was turned down other than that it was some personal failing. But let's talk for a moment about microaggressions. What I'm going to say actually applies to any client when there's a problem or a rupture in the therapeutic alliance. It's really important to be aware of how your patient is feeling emotionally as he's sitting in the session with you. And if you notice an affect shift then there's something you have to do. Now, you might notice this affect shift because the client's tone of voice has changed, or maybe you see it on his face or in his body language. When you notice that, then much of the time you're going to stop and say what was just going through your mind. And no matter what the client says, whether it's negative feedback or neutral feedback, whatever it is, it's important for you to say, well, it's good you told me that. Now, if the client is right about this negative feedback, then you apologize and you tell the client what your plan is to avoid making this mistake in the future. But sometimes clients have negative thoughts about us. They do some mind reading and jump to some conclusions about how we're viewing them or what we're thinking. And in that case, it would be important to help the client look for evidence that his thought about you is accurate or not accurate, and whether there are some alternative explanations for what might be going on. And I could go on and on, but I think it's time for the next question.
Yeah, and let's go to this incredibly complex and difficult, but lots and lots of good ideas there. Thank you. You and your dad established Beck Institute 30 years ago. How do you think CBT and psychotherapy and the field of mental health will evolve over the next 30 years?
Well, I think this is a great question. I think a lot of it is unknowable because it will depend on what research shows us, especially research in genetics and neuroscience and cognitive science and probably in artificial intelligence and all kinds of other things. You know, part of me wishes that within 30 years, scientists would develop an inexpensive pill that had no side effects that everyone in the world could take to reduce their suffering, or that artificial intelligence is so incredibly good that therapists aren't going to be needed. But I don't think that's ever going to happen. I think that, for example, when people have problems in the family, or when there's couples problems, or when people have really severe personality disorders, that probably pills and computer programs aren't going to help well enough. I do think technology and artificial intelligence are going to make therapy more affordable and more accessible. You know, there are already so many computer programs and apps based on CBT, and a few of them are evidence-based, and I would encourage people who want to look more into that to make sure that the apps that they're using or recommending, and the computer programs too, are evidence-based. Now, there's already a little bit of research, and there's going to be so much more, I think, on what kind of treatment or what kind of combination of treatments are likely to benefit what kind of person. I think we're going to see increasingly the use of psychedelics, nerve stimulation, transcranial magnetic stimulation, and even the ketogenic diet for individuals diagnosed with serious mental health conditions. And I'm sure there will be other non-pharmacological treatments that are yet to be invented. Now, in terms of psychotherapy conducted by humans, I think, CBT, again, adapted for the individual with a recovery orientation, and CBT that integrates techniques from all the other evidence-based treatments, as we now teach at Beck Institute, I think that will continue to be the dominant psychotherapy. But that's only if research continues to support its efficacy as compared to other psychotherapies or other treatments. And there may be new psychotherapies that exist 30 years from now that we have no idea about yet. And if research does show that there's another psychotherapy or treatment with a different theoretical framework, different set of techniques, and that's more effective, then that psychotherapy will probably predominate, and it should. Now, I think in the next 30 years, CBT will continue to be applied in more and more settings. Now, for example, it's already being used in schools, in nursing homes, in community centers, in forensic settings, in violence reduction programs, in workplaces, in group homes, in athletic programs, in peer-led support groups, and homeless shelters. Now, I know about these because we're doing ourselves are doing work and training the staff in, and especially the CTR team are training staffs in many of these different kinds of organizations. But I also read a great number of research citations every week, so I find out more and more about this. I do think CBT will continue to be adapted also to be used by different providers, all kinds of medical personnel, occupational and physical therapists, being used already by correction officers and residential treatment staff and clergy. And I hope it will eventually become a standard part of medical care for everyone. The last, I could go on and on, but let me just make one more point, which is I think in the next 30 years, CBT is going to be adapted so that it helps people who don't have psychiatric disorders or psychological problems. I think everybody can use a little help in being able to live in better alignment with their aspirations and their values. I think everybody could really benefit from feeling more connected to other people, feeling more productive and competent. I think, especially in these days, having a sense of hope that things can improve.
Thank you, Judy. Lots of food for thought there. In the couple of minutes that we have left, I'd like to ask at least one or two questions that have been submitted by the audience. And thank you to the audience members who submitted the questions through the Q&A feature. So let me just turn my attention this way, and I'm seeing these questions for the first time. So I'm just going to go right to the first one that pops out at me and pose it to you, Judy. And it reads, in training novice CBT therapists, one of the biggest challenges for me seems to be moving beyond the mechanical application of techniques to developing a deeper understanding of cognitive conceptualization. What strategies do you recommend to help new therapists cultivate this skill effectively, ensuring that interventions are tailored to the individual client rather than simply following a structured protocol?
So, conceptualization really is one of the most important parts of CBT. And so I think it's really helpful to teach people how to fill out the cognitive conceptualization diagram that's in CBT Basics and Beyond. And what I encourage novice therapists to do, new therapists, is to fill out the diagram on themselves. Figure out, for example, at the bottom of the diagram has 3 cognitive models. When you find that you're feeling a little bit distressed or having a physiological reaction connected with some emotion that you're experiencing, or engaging in some behavior that's not very helpful, stop and think to yourself, well, what's the situation here? What am I thinking? That therefore it would make sense that I would have this kind of reaction. And then help them learn how to figure out the top part of the diagram. It was interesting when I first filled this out for myself. This was back probably in 1990 or something like that. And all 3 situations had the same themes over and over again. It was always, I was a mom with 3 little kids and incredibly busy. And all the theme was always had to do with this idea of not feeling enough in control, that I wasn't doing a good enough job at work. I wasn't doing a good enough job as a mom. There was just too much to do. And it was really helpful to me to be able to fill this out on myself. So I think it's really helpful for other people too. The other thing that I suggest that novice therapists do is not to fill it out on any family members or friends, but as you're watching a movie or you're reading a novel, you might think to yourself, I wonder what this person's core beliefs are that then are leading him to behave in this way or leading her to have this kind of emotional reaction. So you don't want to ruin the experience of movies and literature forever, but at the beginning, I think that that's probably a good idea. One of the things that I do when I teach the psychiatric residents at Penn is to have, when they present a patient, we first talk about the conceptualization, and then I say to them, okay, so if you had one of these problems in one of these three cognitive models, so just pick one, what would you do? How would you solve that? And I try to get them to use their own good problem-solving abilities to figure out what it is that they should be doing. Now, learning how to adapt therapy according to the characteristics of the patient is more difficult, and that's why I think it's so important for people to work under supervision. And I'm so lucky to work at the Beck Institute with Alan and our expert therapists because we have a biweekly case conference, and we all present our cases. I present my cases too and get really great feedback from the other therapists. So what I'd also like to say, because I think this is so important, and it's not an answer to your question, but I really see learning CBT as a lifetime endeavor. I feel like I still learn from every single patient that I see and every single person whom I supervise. And it's important for us as supervisors and trainers to be able to give this long view to the novice therapists and encourage them to understand that, of course, they're struggling now. But as they see more and more patients and get more and more training and more supervision, what they're now struggling with will become easier. At least many things will become easier.
Thank you, Judy. We'll do one more question.
Sure.
How can CBT embrace all types of third wave therapies and positive therapy without transforming, disintegrating, or losing its identity?
Well, I'm glad that this question came up because I think it is so important for good CBT therapists to know about the other evidence-based treatments and to be able to integrate the techniques from these evidence-based treatments into CBT when it's appropriate. So I'll just give you one example. When a client is engaged in a dysfunctional thought cycle like worry or depressive rumination, it usually just doesn't help very much to respond to individual automatic thoughts because you respond to one and then another one pops up. And for patients like this, it's very important for them to learn how to disengage from their thoughts, as mentioned in acceptance and commitment therapy, to label them as thoughts and just kind of watch them flow without trying to intervene too much with them. And mindfulness can be incredibly helpful in this way because mindfulness really teaches your brain to be more flexible, to be able to disengage when thoughts are part of this dysfunctional cycle so that you can be thinking about what you want to be thinking about. Likewise, when patients are in a great deal of distress, the emotional regulation techniques that are stressed in dialectical behavior therapy are very important. And I have to say, from time to time, I probably use techniques from solution-oriented therapy, from interpersonal psychotherapy, from compassion-based therapy, from schema therapy, from positive psychology, probably from a handful of others. So for the novice therapist, it'd be important to learn how to do CBT and then to be able to branch out from there and integrate techniques.
Great. Thank you, Judy. Well, unfortunately, that is all the time that we have for this evening. If you missed part of the webinar, or if you want to share it with your friends and colleagues, please check your email as we will be sending out the recording soon. And if we didn't get to your question, I apologize. But Dr. Beck will be responding to many more questions on social media and on our blog. So be sure to connect with us to see more responses from Dr. Beck on a wider range number of questions. So Judy, thank you very much. And thank you to all of you in the audience who attended and participated in this. And we hope that you all have a great night.
Thank you.